This next session, I'm really delighted and thrilled to invite two esteemed, amazing clinicians to the stage with me. As you've probably heard, the last 2.5 days has been the 5th World Congress of Cutaneous Lymphomas. And there were, I think, over 400 researchers, clinicians, and scientists engaged in sharing their research, their information, what's on the horizon, what have we learned, new therapeutics, new insights, experiences, and clinicians from all over the world. I mean, we've got folks from Australia, from Europe, from Asia, everywhere. Everyone was here, which is why we wanted to do our patient program, because we then can have access to some of those folks that you may not normally get access to. And so I'd like to bring to the stage with me, and this will be a little bit interactive, Professor Emmilia Hodak, who joins us from Israel, and Dr. Michael Khodadoust, who's more local. He's from Stanford. But thank you both for joining us this afternoon, because I will tell you, it was a grueling 3.5 days. How many programs did we had multiple sessions? There was 2 rooms.
I think around 11 sessions.
Yeah, it was insane. We can come up here and sit. Oh. And I promised them that they didn't really have to put together very formal presentations, and we would keep this a little bit high level, and a little more informal. So I apologize. Usually they've both been participating for the last couple of days in chairing these meetings and some topics, and also presenting and interacting. And it was an amazing meeting. You think? Yeah. Yeah.
Dr. Hodak was actually organizing the meeting, so soon we'll have a big sense of relief, but it was such an amazing achievement to put together. Yeah, absolutely amazing.
Yes, and Dr. Hodak is the current chair of the International Society for Cutaneous Lymphomas, which hosted the meeting. So it's really an honor and a privilege to have.
Today is the last day of still being the president.
Yes,
Yeah.
president, yes.
From tomorrow, I'm immediate past president. So it's a very special day for me. And I'm happy to share all what I know with you.
It's been great. So I thought we would start with Dr. Khodadoust. And I'll just say that, and I had to miss some of the sessions. I tried to be everywhere, but there were sessions going on simultaneously, so I couldn't be everywhere. But Dr. Khodadoust has an amazing lab up in Stanford and doing some incredible work looking at the new technology and precision medicine and personalizing medicine. And so I'm just going to turn it over to you. Here's the clicker, and then we can have a conversation. Yeah.
Great. Yeah, so I only have 2 slides. I know you guys have been getting a lot of information too. But one of the things I spoke about at the meeting is a concept that's been in development for a long time now. And the issue, as you guys know, is that while we're dealing with one illness, cutaneous lymphoma, it comes in so many different varieties. And even the exact same diagnosis, whether it's mycosis fungoides or Sézary syndrome or whatever subtype, it's still so variable. We call that heterogeneity. So it's different for everybody. For some people, their diagnosis, their disease may not change for a long time. For others, it's changing rapidly. And so that makes it really challenging to treat this disease. And because of that, we really don't have a one-size-fits-all approach for this disease. It's always customized to each patient. And the way we've been doing it for a long time is customizing based on things like clinical factors. So when we see somebody in clinic, we have to decide what to treat them with. And I think it's a good thing. We don't have a you were diagnosed with this is your treatment, because that's what the guidelines or the algorithm says. We look at what the disease looks like. We look at how the patient's symptoms are, how much skin is affected, how much itch there is, where the person lives, what's the person's ability to get treatment. So we use factors that are related to clinical factors. So some of those are what I mentioned. Is it a lot of skin? Is it everywhere, erythroderma? Is it a tumor? Some people have tumor lesions. Sometimes they're ulcerating lesions. What kind of manifestation is there? Is the blood affected? Is the lymph node affected? We choose therapies that work better sometimes in blood, better sometimes in lymph node, or we can choose skin-only therapies, depending on what areas are involved. And we tailor to the aggressiveness. So if somebody has disease that's not really causing many problems and they are doing okay with very mild therapies, we continue mild therapies. There's no reason to switch to something more aggressive with a lot more side effects. And then we think about the toxicity, not just the toxicity of the drug on people's bodies, but the toxicity to their lifestyle, to their wallet. So, sometimes people are having to pay for treatments, and sometimes they have to travel or they have to miss work. Some therapies are infusional therapies every week. So that's how we've been doing it for a long time. And it's still how I think we're going to be basing treatments in large part. But the thought and the hope is, well, we know that while everybody's disease looks different, as we study it under the microscope, as we study the DNA, as we study it in the laboratory, we realize that, well, there's a reason they're different. They're actually different under the microscope. They're all lymphomas. They all came from the same bad cell, but they got there different ways. And that's part of the reason they behave differently. And so we realized that because they got to being a lymphoma a different way, we may have different strategies. Different treatments may work for some patients better than other patients based on what caused that lymphoma. So the hope in the future is that we can incorporate that, not just the clinical factors I talked about, but we can do tests in our laboratories, in our clinics, and decide, oh, you have a certain flavor of this lymphoma, and we know for you this drug is going to be the one. So that's the goal. And so where are we with this? So we have, it's really inspiring. I'm just coming away from the meeting and my mind is swimming with everything I just heard. There are so many strategies being pursued. There are so many methods being pursued. And a few of the more exciting ones, I think, have been coming out in recent years. So we have new classes of drugs that are designed all around the concept of targeting molecules on the surface of lymphoma cells. So this is something we've been doing in cancer for a while. We know that sometimes lymphoma cells or cancer cells, what's on their surface is different than anything else in the body. And if we can find what's different on the lymphoma cell, we can use something that can actually just target that molecule on the surface, that particular one, attack it and kill it. And the key is, can we find something that's really on a bad lymphoma cell and not on a normal lymphocyte? That's a big challenge with especially cutaneous T-cell lymphoma. The problem is you can't just kill T cells. For B-cell lymphomas, we actually have therapies that can knock out all of your B cells, good or bad, and you can live without your B cells. It's kind of amazing. You need a little bit more support. There's some risk with it, but you can't live without all your T cells. So we can't just take that approach that says we're going to kill every T cell in your body, because unfortunately, we'll all die of infection if we have that. So we have to find markers that are on bad T cells that can differentiate them from the good T cells. And there's been amazing work over the years. We heard about, one of the exciting ones is at the very top of the list in trials. This is roughly put into a certain order because KIR3DL2, which is in trials, we just heard some of the data. We're really hoping that that is going to be pushed to approved in the next few years. We'll see. It's going to be evaluated by the FDA hopefully soon. So this whole class, the nice thing is not only do we have antibody therapies, we have new cellular therapies, things called CAR-Ts, where we can actually not just put in a drug that targets that, you can put in a living cell that can target one of these molecules. And the thing about a living cell is they persist. You put them in and they stick around, and they can even grow, they can divide. And because of that, they can overcome actually even the most aggressive lymphomas. We know this from B-cell lymphomas. And the key is, can we find good enough targets in our T-cell lymphomas to bring that technology? And we heard a plenary session about that at our meeting, and we're hearing more and more about it. So that's one of the big goals. Can we figure out what's on the surface that we can target? And the key is, it's going to be different for everybody. For some people, they have CD30. For some people, they don't. For some people, they have CCR4. These are the improved categories. Others, we're seeing it go away. And so we're learning how to match the drug, the green drug with the green molecule, the red drug with the red molecule, based on what's on the surface of the cells. So that's one big area. And I think that, I don't know, timeframes are tough to tell, but definitely in the next 5-10 years, I think that kind of treatment, these very targeted treatments, are going to really come more and more to the forefront because we're getting safer ones, better ones. We've spent a lot of time figuring out which molecules are the right ones to target, and hopefully that pays off. The other way we can look at different people's lymphomas is not what's on the surface of the lymphoma, but what caused it to become a lymphoma. We can look at the DNA of the lymphoma. Lymphoma cells get there by having mutations. They alter their DNA. By altering the DNA, they can persist. They find ways to not die. Normal T cells, our normal body cells, are supposed to die after they have done their job. Lymphoma cells don't do that. They learn to stick around. They learn to grow. And so they have different mutations to do that, but everybody's is different. And that's actually been a huge challenge for this disease, because in other cancers, it's not quite as heterogeneous. It's really like a snowflake. Everybody's lymphoma is different. It's so rare that we find these recurrent events, these recurrent mutations. That's been a big challenge. But the interesting thing is there are a few of these that we do find where we think we already have a drug. We don't even need to make a drug for that mutation, but we know people, we know some mutations that we can find when we sequence the DNA that say, for example, this patient in the upper right, this is a young lady who had mycosis fungoides, and we just kept having problems with this right armpit area. And we would give treatments, and she wasn't responding to anything, and we gave her radiation, we gave her more radiation, we gave her more radiation. Finally, the radiation oncologist said, no, look, the skin is breaking down. We can't keep giving radiation. We have to find something else. And so when we did the sequencing, we found, she has this particular way of making her lymphoma grow. That's actually not very common. This is not something that we see in a lot of people with mycosis fungoides, but we have seen it in some other diseases. And there's even a drug, a pill inhibitor, that can block that mutation. And so we gave it to her. It's something called a JAK2 inhibitor. The drug is called ruxolitinib. And for her, and really it might only be for her because we know it doesn't work for everybody, but for her it was a miracle. And she, after going from therapy to therapy to therapy, from having all this inflammation and all this breakdown there, that's 5 months of treatment. She's been on it for 18 months. She's still on the treatment. So once in a while we find the right one. And the patient in the bottom, one of my particular interests is immune therapy, using the immune system not chemotherapy, not even targeted therapy, but the immune system to attack lymphomas. And the good news is it works sometimes, and when it works, it can really work. You can give this drug an immune therapy, and it can last for a very long time because your immune system keeps protecting you from the cancer. The bad thing is that most of the time it doesn't work. So, and even if it does work, you have to wait a while. It's the immune system. It has to rev up. You don't know if it's going to work. So we don't tend to use this drug very much because we can't rely on it. It works for the minority of patients. You have to wait a long time. So if we knew those people that respond well to this, we could use it a lot more. And we found one feature where we think we can predict who will respond. And again, it's at the DNA level. We can see lymphomas rearranging their DNA in a way that causes them to hide from the immune system. We've recognized that. We can pick it up even in our Stanford clinical assay now. We can just do it by routine testing. We see it's protecting itself from the immune system, and we know it's hiding from the immune system, so we know that that's its weakness, and then we give it immune therapy. And this was a patient who had very difficult to control disease as well, and we gave the immune therapy, and he had this great response. Actually, after the first dose, he had an incredible response. So that's the whole gist of my talk, the idea of everybody's lymphoma is different. We've known that forever, but can we make our treatments more accurate for everybody's lymphoma based on what we're finding in the laboratory? We're getting there slowly but surely. Right now it's kind of little slices of the pie, but hopefully we can find a better way to match these therapies.
Thank you, Dr. Khodadoust. I know that was probably a lot, and that was like this teeny, this much about what went on over the weekend and what's happening behind the scenes. But I think, it's really an honor and a privilege to have you both here so that everyone in the audience gets a sense of what's really happening behind the scenes that you don't ever have the opportunity to know. And I think that's why we do our best with the foundation to try to bring that forward so that there is a lot happening, even though you're still dealing with the disease day to day, but also understand that there's a lot of hope. So we're going to switch gears, and I'm going to turn it over to Dr. Hodak. You want to give her the clicker? We have the clicker there.
Okay.
Dr. Hodak is probably, this is my opinion and my humble opinion, but I think she is probably the most knowledgeable clinician around the globe in pediatric and young adult cutaneous lymphoma. She's been studying it for a long time. She probably has the best knowledge of dealing with children with cutaneous lymphoma as they've gone through their adult life. So she's got a lot of experience and has been really impactful in bringing forward this very small, rare subset of patients. And do you want to sit over here? Is that easier? So I've asked her, there's a lot of work that's been done to really look at the pediatric population, and we've just created some new guidelines. And I think it's really important because we don't often have the opportunity to talk about the kids, and we have kids. Right?
Yeah. Actually, the third time that I'm invited in this forum to give some updates on pediatric dermatology. The first time it was back in 2009. It was in Hilton Hotel in New York City. But since then, we gained a lot of experience with the pediatric MF cases. At that time, it was regarded as exceptionally rare disease, with very few studies reported in the literature. But nowadays, there are more and more studies that are appearing in the literature and indicating that mycosis fungoides in the pediatric age group, namely below the age of 18, can occur, although it's uncommon, but it's not extremely rare. And if, just to give you an example, if I ask my adult patients, since when do you have your rash? Many of them will say, oh, for decades I have it. So they mentioned that the onset of the skin disease was back, for example, in their 20s or even less. So probably it's not as rare as it reflected in the literature. So now I want to tell you that we decided, experts from 3 international society, the ISCL, the International Society of Cutaneous Lymphoma, the EORTC, European Organization of Treatment and Research of Cancer, and USCLC, this you know for sure. We convened together, it was back in Marseille 2021, to try to come up with standardized guidelines for the treatment of pediatric MF cases. Why there was such a need? Because there are no current guidelines specifically designed for the staging and treatment of MF in children and adolescents. And you know that the guidelines for the treatments that we have today just for adults. So what we have been doing for many years, we just looked at the guidelines for the adults, and we follow up them for our pediatric patients with some adjustment. But is it the correct approach? Of course, no. Why no? First, I want to let you know that Dr. Khodadoust, sorry for the pronunciation, gave you an amazing overview about all the advances of the new treatment for cutaneous T-cell lymphoma. But this is mostly irrelevant to our pediatric patients because luckily the vast majority of them have early stage disease, and it's rarely that you encounter a pediatric patient that will progress to advanced stage. So most of our patients have this 1A, 1B disease, and also most of them have very flat disease, not even thick plaques, but just patches. So most of the treatment approaches are what we call skin-targeted therapy, namely treatment that we give just for the skin and not for other compartments like the lymph node or the blood, because these compartments are not involved in pediatric MF. So these are good news. And so now, so this is one thing. Another thing why it's needed, but why there is a need for guidelines specifically designed for pediatric age group, that we know that they have special requirements. For example, phototherapy. Can you offer phototherapy for a 4-year-old child? No, usually no. Or can you offer nitrogen mustard, the chlormethyl gel, what you call, we call it ledaga in Israel. In the United States, it's called Valchlor, yeah. There are no studies specifically designed for pediatric MF cases. So we can't give them such a therapy with certainty about the safety profile. And also, children long live enough to accumulate side effects. So we would like to avoid them from being exposed to therapy with long-term side effects. So taking together all these considerations, we decided that we have to design guidelines specifically for the pediatric population. So these are our recommendations for diagnosis and staging workup of early stage. And as you see here, we just focused on early stage because advanced stage almost never occur in pediatric population. So in patients that are younger than 18, actually the therapeutic, the staging approach is the same as in adults. Namely, we obtain biopsy, we do physical exam to detect lymph node, we obtain routine blood labs. Sometimes we take a blood analysis for FACS, as you know, to detect Sézary cells, although in all my career, I encounter just one child with Sézary syndrome, and in the literature, there are very few cases reported of Sézary syndrome. What is very important in children, in adults, there is recommendation to undergo CT or PET-CT for advanced cases and also for early stages like 1B with plaques. And in children, we try to avoid them from the deleterious effect of the irradiation of PET-CT or CT. So we hardly never do it. If we need imaging, we send them only to ultrasound. So this is one thing. And another thing I would like to tell you, that lymphadenopathy, namely enlarged lymph nodes, are very common in children because they get viral infection very, very often. So for us as a clinician, it's not an ominous sign to palpate enlarged lymph node in the pediatric age group. And you wanted to, okay. So, and there is an algorithm that with specific instruction how to approach children with lymphadenopathy. This I won't elaborate here, but I just want to reassure you that lymphadenopathy in children is usually benign. I can't recall a patient that his lymphadenopathy in the pediatric age group was due to mycosis fungoides. Okay. So these are our recommendations for treatment of pediatric early stage MF. You see on the left side is the first line, and the right side is the second line. The first line, so there is no prioritization of all the options. So we lumped all the options together, and we have to tailor the specific treatment to the specific patient, as the same is the case in adult patient. So first of all, expectant policy. So if a patient comes to us, he is at the age, for example, 8 years old, and he has 1A disease with patches, is it mandatory to treat him? Well, if it's actually a philosophical question. Afterwards, in the Q&A, I will elaborate more. But there are many experts that will avoid treating patient in pediatric age group with 1A patch disease. The second option is potent or high potent topical corticosteroid. We are not afraid of potent or high potent topical steroid in adults and also not in children, as long as they have only 1A disease, namely it's localized disease. But in more extensive disease, we are afraid to give them topical steroids, especially potent or high potent, because we want to avoid the absorption of the topical steroids in children with all the adverse effect of systemic absorption of topical steroids in children. You know, in children, the ratio between, let's say, in children, the penetration of the topical steroids is higher than in adults. So the risk of systemic side effect of steroids in children due to topical application is much higher than in adults. Now, about phototherapy, we give children narrowband UVB. It's quite safe. There is vast experience with children with psoriasis mainly, who are given narrowband UVB. And we know so far there is no evidence for carcinogenic effect of narrowband UVB, neither in adults nor in children. But as opposed to adults, we won't give them maintenance therapy. In adults, we give induction course of narrowband UVB until the patient achieves remission, and then we can switch the therapy to maintenance treatment with narrowband UVB. This is not the case in children. We want to avoid the accumulated effect of UV in children. So once we achieve a complete response, we stop. Or even the best response, and it's a good best response, we stop. Another option is UVA-based treatment. UVA-based treatment, I don't know if in United States is common, like PUVA bath. I don't know if it's still less common, but in Europe and in Israel, it's quite common. So if a patient, a pediatric patient, has thick plaque, or if he has folliculotropic mycosis fungoides, which is quite common in children as opposed to adults. In adults, about 15% of the adult patient will have folliculotropic mycosis fungoides. In children, up to 40% of the children have folliculotropic MF. So in such cases, narrowband UVB does not, the chances to induce complete response with narrowband UVB in such cases is low. So in such cases, we need the UVA because narrowband UVB penetrates only to the superficial part of the skin, whereas UVA has can reach even deeper part of the dermis, including the hair follicle. That's why when you have thick plaque, you need the UVA and not the narrowband UVB. So in children, we try to avoid the psoralen. We don't give them PUVA usually, and PUVA is allowed only above the age of 12. And for children under the age of 12, we don't give PUVA, and also we would like to avoid PUVA in even older patients and also in adolescents. We hardly give PUVA systemic. Instead, we give PUVA buff, but I don't know if you are aware of this technique, so I will skip. Or we combine narrowband UVB plus UVA. So the narrowband UVB will reach the upper part of the dermis, and UVA the deeper parts. So this is a very important take-home message: avoid systemic psoralen in children, because you know that PUVA is a well-established carcinogenic therapy, and patients that get PUVA and for many, many, many exposures, above 200 exposures, have a dramatic increased risk of skin cancer. So the second line, if the first line fails, there is the second line. So the second line is again UVA-based phototherapy, namely a patient comes to us, a pediatric with and gets narrowband UVB, and he fails on this treatment, we can switch to UVA-based phototherapy. Now, what about topical chlormethyl gel, Valchlor? The Valchlor is not FDA approved for young patients. It's approved for 18 years and old. Yet, we use it for children for very small fraction of our patients if we don't have other alternatives. Why we feel it's quite safe? Because we used to treat our pediatric patient with the compounded product of chlormethyl. I don't know if some of you are aware of it, that before the advent of the commercially available topical chlormethyl gel, we used to send our patient to the pharmacies and they compound chlormethyl with Aquaphor as an ointment. And the patient used to apply on the skin with quite good results. And we used to give it to our pediatric patients, and we didn't see any different safety profile than from adults. And also there are some reports in the literature about using this medication for years for children for other type of cancer of the skin that I don't want to get into this. So we feel quite confident, but because there are no real data on the absorption of this gel, we avoid giving them for large areas of the skin, just to localized areas of the skin. So just to 1A disease. And in case the children do not respond to skin-targeted therapy, which is topical steroid, phototherapy, and chlormethyl gel, we tend to add retinoids, and we usually tend to combine retinoids like acitretin with phototherapy. Bexarotene is not approved for children, and there is very, very scarce experience with bexarotene in the pediatric age group. Therefore, we refrain from giving them. Instead, we give them the other types of retinoids, like acitretin, which is more for psoriasis, or isotretinoin, which is more for acne. And what about PEG interferon, Pegasus? You all know it. It's hardly used in children. It is FDA approved for children with hepatitis. So we have data on the safety profile. Still, we hardly need it, and there is one caveat. It hampers the growth of the children. So we refrain from giving it after the age of 12, when they start the surge of the growth. So we give them before, or if there are no other options, we have to consult with the endocrinologist and to follow up very carefully the growth curve of the child. What about methotrexate? Methotrexate has a great safety profile in children. For decades, we used to give it to psoriatic patients under the age of 18, and it's more tolerable in this pediatric age group than in adults, but it's hardly needed in MF in children. But if we decide to give it, we feel quite on a safe ground. And the last thing, topical bexarotene, it's off-label among children. It's not FDA approved. And I personally don't see the indication to give topical bexarotene with all the to a child, specifically when I have so many other options to give him. So to wrap up, when you have when you diagnose a child with MF, you have, first of all, to avoid from CT, PET-CT. You have to avoid for topical steroids on large areas of the skin, and if you give topical steroids, not for long term, preferentially narrowband UVB and not PUVA. And if you need PUVA, avoid Soralen, give just the UVA. And if there are no other options, we do give chlormethyl gel, but on small areas of the skin. But I would like to tell you that overall, most of our patients respond to these therapies, and the hard-to-treat patients are very limited. These are very limited numbers of hard-to-treat patients. So as physicians that treat adult patients with MF and pediatric patients with MF, it's less challenging to treat pediatric MF patients than adults. So with this, I just summarize for you in nutshell what have been done with the guidelines for pediatric MF. And Susan, you are the boss.
Yeah, I'm not choking, sorry. Thank you both. Excuse me. Wow, there goes my voice. Thank you very much. And there's probably so much more we could share, and I know we're coming up to a break. And then we have our last piece of the program. Dr. Zane will be with us to talk about artificial intelligence, which was a big topic as well at the meeting. So just want to thank you both for taking the time. I know it was end of a long couple of days, and there's a lot of great information. And next time I'm going to talk to you about folliculotropic. Dr. Hodak is also one of the experts in folliculotropic MF, so we'll get her back to talk about that. Maybe we'll do a webinar. But thank you very much, and in small appreciation for your time and your knowledge and for joining us after a very busy week.